Now, a woman who is looking for a pregnancy and she doesn't have any symptoms, she has a stage 4 endometriosis. So, what she should do and how we should go about it. In our practice, what we do is if a patient who has a stage 4 endometriosis, we assess her ovarian reserve by androgen follicle and by, and if her androgen follicle count or AMH is very low, we do offer them egg pickup and freezing if endometriomas are not very big. And after that, we tell them to go for excision surgery before transfer. So it is again case based. We have to tailor endometriosis treatment. I said this does not fit all. Now, a patient who is looking for fertility and pain both. Now, excision expert says it reduces pain, but the surgery can reduce your ovarian reserve as well, and she's looking for fertility also. Now, IVF expert advises against the surgery. So she becomes confused and she's in a dilemma what to do. So it is our duty to give them the right advice depending on their ovarian reserve, depending on their organ involvement, depending on their DIE, that is deep infiltrating endometriosis. Now, how we should approach the endometriosis patient, average consultation time should be 1 hour to 2 hours. We should listen to them. Listening is an art. Taking detailed history, we should see the pain types and ask them the visual analog score for the type and location of pain, examine them properly, imaging, ultrasound or MRI. We should plan their management and appropriate reference to other specialties, if any. Anamnesis is an art, and if you know the facts that after asking patients to express their concern, physicians were able to listen to patients' stories for a median of only 18 to 23 seconds before interrupting in some fashion. So most of the patients say that my doctor never listened to me. So this art, all of you should develop, and first just listen to them, what they want to say. And believe me, listening to them reduces their problems to half. Because most of the time at home, nobody is listening to them because they're saying pain, pain, pain all the time. At maybe the husbands are not listening to them. And if we also don't listen to them, then they become more disappointed, and it further increases their pain by central sensitization. Now, informed consent and shared decision making is very important. Gynecologist gives patients adequate, accurate, and understandable information and requires that patient has the ability to understand and reason. Now, consent is not just a paper of a few points and getting it signed by the patient. Consent is something where we have to make the patient understand what procedure we are going to do and what can be the long-term or short-term implications of that. So there are 4 components of informed consent. One is decision capacity, documentation of the consent, disclosure, and competency. If you can't do a procedure, you have to admit to them. You just cannot say that this is more harmful for that. So endometriosis patients, when the bowel is involved or they have a frozen pelvis, patients are told that surgery is too dangerous for you. I tell my patients run away from there and look for another opinion. Now, endometriosis, medical therapy, surgery is too risky, ablation. Now, endometriosis is an iceberg phenomenon. What we see, it is much more than that. Ablation is just burning the surface lesions and it does not help. We have to scoop it out. We have to excise it. Now, patients are also offered hysterectomy as an endometriosis treatment. Now, offering hysterectomy is like removing a kidney for a liver disease. Now, patient is having problem outside the uterus and we are offering them hysterectomy. So hysterectomy may be offered if she has a consequent adenomyosis and not for endometriosis. A signed consent document, however, does not guarantee that patients' values and priorities have been taken into consideration in a meaningful way and that the ethical requirements of informed consent have been met. It should be accurate and unbiased information with appropriate reference. This is how a multidisciplinary team for endometriosis management looks like. There should be a gynecologist, urology. Gynecologist should be trained in endometriosis excision and to identify all the lesions. a urologist or a colorectal surgeon, reproductive endocrinologist, an infertility specialist, pain management, psychological counseling, integrative medicine, sexual health, physical therapy, imaging, and pathology. These are very, very important for running the multidisciplinary unit for endometriosis, and we do run that. Now, deep infiltrating endometriosis is a phenotype of the same disease. It includes two locations, the anterior compartment and the posterior compartment. The anterior compartment is the bladder, posterior compartment is vagina, uterosacral ligaments, rectum, and ureters. But can also involve ileum, sigmoid, diaphragm, and other less common sites. DIE as the involvement of endometrial-like tissue with a depth of more than 5 millimeter. You can see these are all blue lesions, black lesions, this one, these are all are endometriosis. Deep infiltrating endometriosis typically refers to endometriotic lesions involving the rectovaginal space and occurs in approximately 20% of women with endometriosis. It infiltrates the vagina, rectum, cervix, and rectovaginal septum, and in some cases can completely obliterate the Polter-ducts. Now, there is a difference in ablation and excision, what I was telling you. Now, ablation is just burning. The roots are left behind. Now, excision is completely scooping it out. This is how excision works. So critical factors, there are individual and clinical factors, preoperative morphologic characteristics from imaging, surgical considerations, impact on quality of life. Preoperative planning is fundamental for defining the optimal therapeutic strategy, patient counseling of treatment options, and when surgery is indicated, involvement of a multidisciplinary surgical team is required. What as a surgeon I should know before I take a patient for surgery? Distribution of lesions, parametrial involvement is there or not, multidisciplinary approach, and extent of resection of particular organ involvement should be well informed to the patients. There are several imaging modalities: transrectal, transvaginal ultrasound, MRI, CT, and colonoscopy, but the most sensitive are the USG and MRI. Ultrasound sensitivity and specificity 98% and 100% with the use of transrectal and transvaginal ultrasonography. It all depends. It is operator dependent. If your sonologist is trained or they can pick up the lesions, then nothing like that. Because I have a sonologist in my team who can map all the lesions, and it makes my counseling to the patient and avoidance of complications very, very simple and easy. MRI was shown to have a sensitivity of 83% and a specificity of 98%. Transvaginal sonography with water contrast in the rectum has also been demonstrated as effective in detecting endometriotic lesions in the bladder, with a sensitivity of 96% and a specificity of 90%. Intestinal involvement by deep endometriosis nodules has been estimated to occur in 8 to 12% of women with endometriosis. So urinary tract endo is 1%, 85% involve the bladder, 10% ureter, 4% kidney, and 2% in urethra. Now, this is one of the videos of the surgeries for deep infiltrating endometriosis along with the peritoneal involvement. As a routine for all the patients, we prefer to do a hysteroscopy and cystoscopy. This is a young girl, so hysteroscopy is important for seeing the cavity. These are the peritoneal nodules. You can see on the round ligament and on the peritoneum. Always look at the whole abdomen, look at the undersurface of the diaphragm. You can see the peritoneal lesions. These are overlying the ureter. So it is very important that we know how to do these dissections so that we safeguard the ureters and we do not damage the bowel and avoid complications. So in this case, I must tell you that most of the gynecologists, everybody does endometriosis, but excision hardly anybody does. Now, they will have endometriomas and chocolate cysts, they remove the chocolate cysts, but no one removes these peritoneal lesions. If you remove these peritoneal lesions, the recurrences are less, the quality of life is much better, and their number of multiple surgeries can be reduced. So these all lesions are removed. There were some lesions on the bladder surface as well. So first step in these surgeries is the sigmoid mobilization. After sigmoid mobilization, the ureterolysis is done on both the sides, tracing the ureter up to their path till the uterosacral insertion, because they most of the time they will be very adjacent to the uterosacral and there can be ureteric injuries. So this is called as uterine suspension, which we are using here. So if you do uterine suspension, the hanging of the uterus through the anti-abdominal wall, and it helps in making one of the assistant ports free, and we can do the surgery nicely. Also, ovarian suspension we use so that we can do the posterior dissection very well without any uh, interference and using multiple instruments. In these cases, most of the time the ureter will be medialized. So if it is medialized, we have to take care of the ureter so that we don't damage. This is how the anatomy looks like. There's a bladder, the uterus, the rectum, and these are the ureters, and these are the vessels and hypogastric nerve. So this is how we do, and I'll show you what we usually do. We do the posterior peritonectomy in all these cases. We remove the peritoneum where cell rest can be there, which can give rise to endometriosis later. So if we remove it completely, we can reduce the chances of recurrence. Now, this is adenomyosis. So after doing the endometriosis excision, we have also removed this foam component that is called as focal adenomyosis of outer myometrium. And this is the suturing which we are doing on the uterine surface. This is the ureter. Now, this is the technique which we use in most of our surgery. Like we mobilize the sigmoid, we do the ovarian mobilization, suspension of the uterus and ovaries, uretrolysis, rectovaginal and pararectal space creation, and excision.